We're going to talk really briefly about equity, diversity and inclusion work that we're doing in the Upturn study. And I'm going to talk about some of that EDI work, and Tracy's going to talk about PPI and community engagement. And I'll start with a very brief overview of the Upturn study. Next slide, please. So we know that for clinical trials to be ethical, just and fair, they need to be inclusive. Participation needs to be accessible regardless of social or ethnic background. But we know that certain groups of people, including ethnic minority communities and people with other protected characteristics, are often underrepresented, and there are many repercussions or impacts, and some of these are listed here. Next slide, please. The Upturn study is a new study. We're just at the start of the research phase. It's a 5-year study funded by the NIHR, and it aims to support people with COPD. It's led by Dr. Jonathan Fuld at Cambridge University Hospitals, and the team includes our partners Asthma and Lung UK and researchers from across the UK. Next slide, please. We'll be doing specific work with Bangladeshi, Caribbean and African communities that are disproportionately impacted by by COPD, so used to talking about COVID. And on Monday, we had 4 new people joining our team with cultural, linguistic, community engagement and research skills needed to engage and work meaningfully with our communities. Next slide, please. So just a bit of background on COPD. It's a common lung condition, and it causes breathlessness, persistent cough and wheezing. Research has shown that pulmonary rehabilitation, or PR, is transformative treatment for COPD, and it includes supervised, tailored exercise and an education program to support people to manage their symptoms and live well with COPD. PR has been shown to reduce breathlessness, it's been shown to reduce hospital admissions and to improve quality of life. Attending the initial assessment appointment is the gateway or the introduction to engaging with PR services. Next slide, please. Some ethnic minority groups have higher rates of COPD than others. And as you can see on this slide, Bangladeshi communities are most severely affected, particularly Bangladeshi men. Caribbean and Eastern European communities are also disproportionately affected. Next slide, please. Despite the research evidence on PR, attendance at the initial assessment session is low, and there are many understandable reasons for this. Attendance is particularly low for people from ethnic minority groups. COPD is associated with social deprivation, where often there are higher rates of smoking and exposure to other hazards. And the aim of Upturn is to provide a personal, culturally sensitive support package that could increase the number of people who attend PR and therefore benefit from it. Next slide, please. So if you click on that again, please, Tom. Yeah, so we'll be working with patients and carers from all groups, and we'll be conducting specific work with Bangladeshi, Caribbean and African communities to identify the challenges to attending PR assessment and ways to overcome these. So we'll be running separate single-sex focus groups starting in June with Bangladeshi men and women, with Caribbean men and women from a range of African communities. We'll then be running co-design workshops, and we'll be working with ethnic minority groups to co-design the intervention right from the start, rather than trying to culturally adapt the intervention later, as is often the case. We'll be conducting interviews, and we anticipate that the support package will include culturally appropriate telephone support and information about the local community PR class. So information, for example, in multiple languages and formats, including video and audio. We will test the support package with 40 patients to ensure acceptability and feasibility, and then to test the intervention in a clinical trial with 1,580 patients to find out if people receiving the support intervention are more likely to take up and benefit from PR compared to those who don't. So some people will be randomly assigned to receive the support package, others will receive usual care. We'll evaluate the clinical and cost benefits and the best ways for Asthma and Lung UK to provide the support package in community settings. Next slide, please. So where are we at the moment? And again, please, Tom. And yeah, one more. Yeah, we're at the start of the research, and in the coming weeks, we'll be translating the study materials, the participant information sheet, and the consent form into Bengali and Sylheti, so that the study materials will be available in written, audio, and video formats. We want to ensure that we include people who don't speak English as well as those who do. And the recruitment to the focus groups will be through community organizations, faith centers, our PPI leads who are also community leaders and champions in their own communities. Next slide, please. If you click on that. Yeah. The EDI work stream runs through the whole 5-year project. And we've got 4 key objectives, including leadership to ensure that EDI expertise is applied throughout the study. We want meaningful involvement in terms of the ethnic minority groups that we're working with. We'd also like to build research capacity and health literacy in the groups that we're working with, and to share our learning on conducting inclusive research with funders, other research teams, and other stakeholders. We've drafted an EDI strategy, and our plan, and this is all work in progress at the moment, is to embed inclusive actions in every aspect of the study, starting with our research team. Next slide, please. So we have quite a diverse team that we're working with, including community researchers, people living with COPD. We're setting up community-specific PPI groups, as well as a broad overarching group, bringing together academic, clinical, cultural, linguistic, and experiential knowledge. We have an EDI management group that meets monthly to review and monitor our inclusion aims and to ensure that we're consistently working towards our objectives. And we'll be having quarterly internal strategy reviews and quarterly external reviews by the EDI Oversight Committee, which is an independent group whose role will be to hold the project accountable for EDI performance, to provide direction, support, guidance, and recommendations on our work. Our first meeting is set up for the end of June, and then we'll meet up every 4 months after that. Training is also a part of the strategy and capacity building, including cultural competence training for the whole team. We'll be building capacity by providing training to the community researchers, including training in conducting inclusive research, qualitative methods. I'm a qualitative researcher, and thinking ahead in terms of fellowship applications and doing a PhD. We'll be providing training for the PPI members, staff at Asthma and Lung UK as well. Next slide, please. So research inclusion is a big part of the work in Upturn, and we'll also be discussing inclusivity throughout every work package. So one of my roles will be having kick-off meetings with each work package lead to discuss inclusion, and to have regular meetings to review and constantly monitor our own progress in terms of our EDI objectives. EDI considerations, for example, and we haven't started this work yet, will include how to recruit a diverse and representative sample to the trial, inclusion and exclusion criteria. We'll discuss accessibility, culturally appropriate study materials, dissemination and sharing our findings, knowledge exchange, all of these things through every work package. There's a study within the trial in work package 2 where we'll be investigating the impact on trial recruitment and retention of a community researcher, someone culturally and linguistically matched, taking consent compared to a university-based researcher. Next slide, please. And finally, we'll also be conducting a formative evaluation to determine the barriers and enablers to delivering our EDI activities. We'll develop recommendations for conducting more inclusive health research, which we'll share with other researchers and with funders and with the communities. And I'll hand over to Tracy now, who will talk more about PPI. So we hope that we are embedding EDI throughout the whole study, just as we want to be embedding PPI throughout the whole study as well. So over to Tracy.
Thank you very much, Suman. My name is Tracy Cripps, and I'm a PPI co-applicant lead on the Upturn study. So Tom, if I could have the first slide, please. So I'm going to try and move the presentation on a bit now and just try and share some insight and overview actually into the Upturn PPI work. I'll touch on three brief areas, mainly some of the things that shape the thinking behind the Upturn PPI plan, what we've learned from the PPI work that we've done, and then how that learning will be reflected into best practice moving forward. The next slide, please, Tom. So for those of you that may not recognise it, the black virus actually is HIV. And if I could cast your minds back to the early 80s and 90s at the height of the epidemic for HIV, which really was predominantly in gay men, you know, the behaviours of the people contracting HIV at the time was very, very little understood. And research and behavioural change models were ineffectual because we had straight white men with clipboards trying to do the research. And actually, it was only when we sent gay men into the communities where gay men congregate and meet socially that we began to understand behaviour. And then some progressive research came out, and that sort of supported research into change. In a likewise manner, the red virus, as I'm sure everybody will recognise, is corona. And very much in a similar way, the BME and underrepresented communities were disproportionately affected, and we were dying in huge numbers. And actually, there were a lot of fear and myths around vaccines, and you know, it was a terrible episode, I think, in the NHS history that we'll never forget. But actually, meaningful change only became apparent when we went and spoke to community leaders, we went to mosques and we interfaced and spoke to imams, we went into churches, spoke to pastors, and we really began to understand the barriers, and then were able to effectually understand those behavioural impacts and make changes. And so what did we do? We sent buses into communities and we set up vaccine clinics in mosques, etc. And then behaviour changed. In a likewise manner, actually, with our previous work that we did in our RFPB bid, which was on a mixed demographic of white and British Pakistanis, that research learned and taught us actually that there were some key barriers that were very apparent and hindering how people viewed PR. And those were pretty much predominantly at the individual patient level barriers, and most of those were around a lack of understanding of PR. There were negative perceived beliefs, fear of judgment or shame, and a negative experience really, which happened at PR referral. And we recognised very early on that we wanted to address this in order to make some changes. And the other image that I've got there on the screen is obviously some of the behaviour change models, which naturally we consulted as well in the thinking around our PPI planning. Can I have the next slide, please, Tom? Thank you. So what did we do and what did we learn? So at the very basis and foundational core levels, actually, one of the things we wanted to address was diversity in the research team. And we wanted to make sure that the thinking around anything that we did with Upturn was constantly checked, if you like, and progressed with the people that we wanted to benefit the most. So actually, we recruited a Bangladeshi PPI co-applicant, and we also recruited another co-applicant which directly suffered with COPD. So these 2 lay PPI co-applicants are actually costed into the grant. They are direct members of the study team. They attend all meetings and their voices are constantly and consistently heard within the formalities of the research group. So their presence is constantly fed into what we do and is constantly shaping the work of Upturn. One of the other things that we did is we directly recruited from within the communities that we want to serve community researchers that Suman has already referenced. So we recruited a Bangladeshi man, a Bangladeshi woman, a Caribbean researcher, and an African researcher. So why did we do this? So if you think about the previous slide and what it showed, the examples reference what happens and what the terrible outcomes are if people are not overlooked. And if that underrepresentation references itself, well, we don't really understand the barriers. Our previous RFPB work also taught us that our engagement needed to be meaningful. But actually, what does meaningful engagement really look like? For a start, you can tear up the script completely if you think that any BME group will fit into a Monday to Friday 9 to 5 box. We learned very quickly that meaningful engagement means meeting people in their turf, in their settings, and at times that are convenient to them. This really demonstrates value and appreciation. Often meetings take place in the work that we've done in the evenings or weekends, often avoiding prayer times and having the same conversation sometimes with men and women separately, pretty much moving Muhammad to the mountain. You know, one of the other things that we have to consider as well in our PPI meetings was factors such as community politics or community dynamics, really important, so that all voices are heard and not one overpowers another. Through the work that we've done, we also learned that food and culture go hand in hand. Breaking bread together builds trust, lowers barriers. Food needs to be culturally appropriate and from trusted sources, so ensuring that food is halal if we're working with the Muslim community, or kosher. We also found that we should allow, particularly when face-to-face engagement it can sometimes be more meaningful, that meetings should be led and driven by the community. This allows the community to take ownership of the work, and it drives another level of commitment. This also builds incredible trust. Communication is another factor that is king. You know, I can't express enough really how much you should let the community tell you how they want to communicate. Make no assumptions. For us, in the work that we did, the Bangladeshi community have very well established WhatsApp groups, and they have that across all their community leaders. So for example, once a parameter was agreed, like a blog or a communication that we wanted to get out there, we could literally get it out to a whole region like the east of England in minutes. TV and radio were another form of communication and media that was very key and critical to our Bangladeshi community and very much dominated social structures. But within our Bangladeshi community, we found that technical modes of communication like the internet or anything on the web was not the social norm, and that for them as a community, they pretty much viewed themselves as being behind the curve. So use what works. Another key factor that we found in our work was don't make any assumptions on homogeneity. For example, people often generalize the Black community. So in America, they'll say African American. In England, we'll use terminology like the Black community. I can tell you now that the Black African and Black Caribbean communities are not a homogeneous group. We are very much separated by language, culture, cultural norms, cultural appropriateness, food, religion, and belief systems. So, you know, we cannot just brandish people under one umbrella, because we will get it very wrong if we do that. So these are the reasons really why we invested so heavily in our foundational pieces. We recruited community researchers who look like and understand deeply the cultures that we want to work with, who spoke their language and really understood them. So what's in it for me? That's up there as a really key and probably one of the most crucial points on this slide. My previous colleague, Lynn, actually touched on this earlier. And I can tell you that there's a general lived experience and perception across BME communities where they feel undervalued and unheard and almost like they're being used. I can tell you that when we launched our project in November, we inverted that model, if you like, and turned it completely on its head by centering our event around the communities that we were working with. We wanted them to take the ownership and the leadership in the event, and we merely facilitated. So they did take ownership and they led. They chose the location, the food, the theme, the media. We supported and facilitated that, and the event was very successful and 150 attended. The presenters that were at the event were chosen who not only spoke about PR, but also other matters of health interest to the Bangladeshi communities that would raise awareness for them. So things like maternity and research that was happening in Bangladesh. So this was all key because what we did as a research team is we didn't put the focus on ourselves. We put the focus on the community and the communities that we aim to serve. We removed completely the feeling of take, and what we did instead was we gave. Can I have the next slide, please, Tom? So supporting the co-design and study objectives of Upturn, you know, what does that mean? Well, it's a very exciting time, as Suman has said. We're just about to start with our focus groups. And some of the points really I've already touched on, like communication. We'll be exploring an array of media, as again, Suman touched on, so TV, radio, video, translation. But really importantly, I will express again, being led and listened to by the community. Consult and involve, that's a really important factor. So for example, if I could draw your attention to our Upturn study logo, this actually was based on a design by our Bangladeshi PPI co-applicant, and our other CPOD co-applicant also influenced the colour palette by highlighting to us the difficulties for people with sight impediments. So PPI done well really does yield dividends. The hands, if you like, in our Upturn logo demonstrates a sense of community, and the rice sheaves themselves were inspired by the Bangladeshi national emblem. So putting this Upturn logo together was really an indication of our commitment to them and is a visual demonstration of their contribution. Really, really important in finding ways to demonstrate value, their value. Remuneration is highly important. And again, I'll say a salute to Lynn here, who touched on this earlier. It's really important to recognise the contributions of the communities you're working with, and really important to think about how you do this. People in the community that you're working with are usually underrepresented groups. There may be people there on benefits. So a bank transfer, for example, could potentially push people above the benefit threshold and act in and of itself as a barrier to them participating in PPI through fear of reprisal with benefits. We use vouchers, but be prepared to think outside of the box. Another thing to consider is being sensitive in your dealings in general. So as I mentioned, we use vouchers, but always consult and ask your community which vouchers they want and where they want them from. It could be really easy to offend or insult completely accidentally. Build strong relationships through honest and open conversations. Always be transparent. Really, really important. Again, on a note for dissemination, and I'll nod to Lynn again here, who mentioned this, really important to incorporate and include your community engagement right to the very end of what you're doing. Can I have the next slide, please? I've just realised I think I've missed a slide. Open back somewhere. I've missed a slide. Sorry, Tom. Can I ask you to go back? And back again. Yeah. I don't know what's happened to it. I think I've got a slide missing, but never mind. I'll carry on so as not to throw the timings out. Yeah, there's a slide missing somewhere, I think. Where was I? So just again, being sensitive in your dealings, from a dissemination point of view, include and incorporate your community's engagement right to the end. You know, don't just think you can step in and use these communities and this wonderful engagement and rich engagement from them to get the data that you want and then cut and run. You know, be led by them and allow their contributions to go right to the very, very end. Destabilize the power vacuum. And again, this is something that Lynn touched on as well. Good PPI should be shared power to the people. And I think it's really important to empower to power. Most people have bad lived experiences of healthcare services, let alone ever imagine that they'll participate in research. So actually, as a Black woman that is in research and part of a really important piece of research, I feel actually duty bound to level people up. I think it's really important that we give back, and we should offer PPI training and opportunities for development and support. But equally important that we ask them what they want and don't assume or push what we actually think is right. We need to understand from them what their needs are. Ultimately, this will perpetuate right through the communities. It will lead to upskilling them, educating them, delivering them into a sense of purpose. PPI should leave a positive footprint. It's transformative, a real opportunity for communities to be heard. Finally, I would actually touch on the budget. Budget is a really key thing. It's easy to underestimate PPI budget. Think about the venue, the location, travel, people's time, catering, all of that stuff. Be as comprehensive as you can. I'll stop there. I think I might just be over. I'll stop right there. Thank you very much for listening.